The great thing is there are new and old friends here at the table, and not only for me, but these are people who often work together, so they can really work off each other on some of these important issues. So Jen Cates is the Vice President and Director of Global Health and HIV Policy at the Kaiser Family Foundation. And if many of you who have worked in this field know, the Kaiser Family Foundation has been dedicated to addressing this epidemic since it began and is a major force in the public reaction and response to this epidemic. Jen oversees the Foundation's policy analysis and research focused on the U.S. government's role in the global health and on the global and domestic HIV epidemic. She's a published author and often presents on these topics at conferences here and abroad. Dr. Donna Sweet is, many of you know, the current chair of the Academy and a practicing certified HIV specialist caring for patients with HIV for more than 25 years. And let me just thank you for that. As somebody who's had friends and family get HIV care from caring doctors, we don't take a lot of opportunities to thank you and for all that kind of work. She and her team currently care for approximately 1,200 patients living with HIV in Wichita and 3 outreach clinics in rural Kansas. She's past co-chair of the CDC HRSA AIDS Advisory Council and currently the national vice chair of the Health HIV Board, where she's leading an effort to address the U.S. HIV medical workforce shortage issues. Courtney Mulhern Pearson joins us from the San Francisco AIDS Foundation. So picking up on the conversation that Dr. Cha started about the California waiver, not just that issue, but we've got an expert from on the ground in California. She's Director of State and Local Affairs for the AIDS Foundation in San Francisco. She's responsible for developing the Foundation's state legislative and budget agenda and advocates for full funding of HIV care and prevention programs in California. And again, the San Francisco AIDS Foundation, one of the earliest NGOs that just arose from the community to fight for and fight back for this epidemic. So we're glad to have you here. Amy Killalay is a senior manager with NASTAD, the National Alliance of State and Territorial AIDS Directors, working with their health care access program. She's helping to lead their health care reform implementation efforts. And NASTAD has, as you can tell by the name of the organization, they have representatives from every state in the country who have been working both at the state level but here with the federal government to really make sure that the federal response is sensitive to the state needs and really hearing directly from the people that are on the ground rather than here in Washington trying to work at the national level. So a very important collaborative. Jeff Crowley is recently the President Obama's Director of National AIDS Policy and a senior advisor on disability policy for the President, an internationally recognized expert who has been working on this epidemic from both the government level and the private sector level and academia for many years, despite his youthful appearance, I swear. He's been working on this for a long time. He had a real critical role in the development of the Affordable Care Act as it affected not just people with HIV/AIDS, but all people with disabilities, to make sure that the act, when it was finalized and as it's being implemented, really addresses the very special needs of those populations. And did I get everybody? Okay, there we go. So let's just start off trying to build on the conversation that we just had. Let's start with the sticky issue of Medicaid. So now the Supreme Court has made the Medicaid expansion optional for states. One, what can organizations and individuals like the people here in this room do to advocate for their state to adopt this expansion? And then perhaps even more importantly, how do you see that expansion playing out, particularly vis-a-vis the Ryan White program that has been so important both to people with HIV/AIDS but also their caregivers? I'm going to just start with Courtney and move things down this way, but after this first go around, just feel free to raise your hands and I'll try to pop around.
Is this on? Okay.
Great.
So thank you so much for having me. I'm pleased to be here and bring some of the lessons we've learned from California to all of you, and I hope you can learn from our experiences and maybe not repeat everything we did. So the question in terms of, I feel like I'm not entirely qualified to speak to states that are not planning to do the expansion, because I'm obviously in a state that is moving ahead very aggressively with expanding Medicaid. You can handle you can handle that part. But from a very outsider, maybe naive perspective, it seems like we need to reach beyond sort of our normal advocacy alliances, and I think working with, well, not that they're not normal partners, but really looking to the hospital groups, pharmaceutical companies, insurance companies, other sort of allies that really will share our goal of expanding Medicaid to this population. From an outside perspective, seems like a start. And then in terms of 4 states that are choosing to expand, I think, and specifically for people with HIV and our providers, we expect, at least in California, I think this is true nationally, that about 70% of our Ryan White clients in California will be moving into Medicaid or are already moved into Medicaid. So obviously as providers, that's going to be a big change for us. So really making sure that you are connected to the Medicaid program in your area. In California, we've also moved forward, again, very aggressively with mandatory managed care. So currently all seniors and persons with disabilities must be in managed care. So starting that process now, we found that the contracting process is quite difficult, and that there's not enough technical assistance available often. So again, using opportunities like this to talk to each other, AHIVM probably can be helpful in sort of helping facilitate some of that as well. But again, I think Dr. Cha said it well, the work really needs to start now. And making sure that we're ready for this population when they fully transition.
Thank you. Well, there couldn't be more contrast between states, between California and Kansas. So Donna, if you could talk a little bit about what's happening in your state, but also how you think those kinds of coalitions might work in other states as well.
Certainly. I sort of empathize with a number of the speakers that were at the mic. Being in Kansas, the governor has not only stated that he has no interest in exchanges. I was part of a Medicaid advisory group that applied for some of the early money to be able to plan exchanges. Kansas was one of the lucky states that got $31.5 million. And the minute my governor took office, he sent it back, saying that we don't need federal help and we're not going to do exchanges. So that sort of sets the stage for where we are. He's also not about to even address the Medicaid expansion issue until after the November elections. He still considers it a repealable, revocable law, that he intends to stay with that premise until the very end. So we'll see what the voters do. But the real issue I think we're going to have, even if we could get Medicaid expansion, in Kansas there is a dearth of physicians who will take Medicaid at all because of the sort of the hoops you have to go through as well as the low pay for what you do. If indeed we suddenly covered the 141,000 people in Kansas who would be just general patients, not HIV, but 141,000 people who would supposedly have access and have a Medicaid card, does not mean they have care, because there are nowhere near enough providers to take care of that population. I think the other real challenge for those of us, I have, as the young woman from South Carolina said, I think I've built a very good program, thank goodness, because of HAB and HRSA and their programs. We have put together a comprehensive medical home for well over 1,200 HIV-infected individuals that I can give them comprehensive care. There is no way that is maintainable with any sort of the current pay mechanisms that are out there for Medicaid and private insurance, because the infrastructure would go away. One of the things that Dr. Cha said was that we have to try and figure out how to, build that infrastructure. The problem is you can build it if you don't sustain it with the appropriate amount of resources. You can't continue to do it. And I think therein lies the real frustration of those of us who have built, as Kevin has out there, and Jim, and all the people that have big long-term HIV functional clinics, to see that come apart because of new funding streams is going to be very difficult for those of us who have watched it for so long. So again, I think the chief problem, even if we expand Medicaid, is going to get providers in it. Even those who want to be a part of it are going to have to learn to jump through these hoops in terms of how to fill out the forms and how to end up being on the right managed care contract. And quite frankly, there may be some bias on the part of many of the managed care companies not to include the people who they very much should have in there that are HIV experts for various reasons. So I think there are so many challenges ahead. And again, we were all waiting for the Supreme Court decision. 90% of it was what I'd hoped for. I don't think any of us really, I certainly never foresaw this part of it, with not making Medicaid expansion something that had to be done. I think it being an opt-out phenomenon is going to be very difficult. But we're still going to have problems with the rules about if there is any sort of Ryan White funding, funding of last resort, and all of the things that have been brought up. So challenges, and we still have to continue waiting because I don't think many of us, the governors that are leaning one way or the other, aren't going to say anything until after the November elections.
Jeff, you've been on both sides of advocacy and being advocated too. What's the best way to make this argument, whether you're in a state that's totally resistant or one that says they're going to wait and see? What are the best arguments in this issue?
Well, I'd say a couple things. I mean, first, I'd like to build on what Steve and others have said. You know, insurance matters. And so we can be concerned about what's going to happen, but people will be better off when they have a right to a defined benefit package under Medicaid. So I think it's something we want to happen. As Donna said, I think we really need to just wait to have this conversation to some extent after the election. But I do think that, you know, she convinced me over lunch that her governor probably won't take up the expansion. But I don't think really other states can say confidently what's going to happen. One, it's not up just to a governor. It's a governor and a legislature. But there's so many incentives why they may really, at the end of the day, expand Medicaid. Just the high level financing available, but also the other things in the ACA, including the cuts in DISH payments that fund uncompensated care. So there'll be a lot of pressure. But I think that, you know, for us to make it happen, we just need to be making the unequivocal case about why it's a good thing at the state level, you know, for so many people. The other thing I would just say is, you know, just to hear Steve talked a little bit about what happened in California, and I think, you know, I'd say a couple things. One is that sometimes I hear anxiety within the HIV community about what we're going to lose with Ryan White, as though Ryan White's the only place that people with HIV get good care, and that's just not the case. You know, Medicaid is the largest payer for HIV healthcare services in this country. A lot of people get good care, and I think it's possible. So I don't think we need to overstate our anxiety about this. But there's no doubt, and certainly when I could speak for the administration, what we always said is, even after the Affordable Care Act's implemented, we're still going to need a Ryan White program. So part of what we need to do is make the case for why we need to expand Medicaid, but then adapt Ryan White so that they work in complementary ways. Jen.
Well, it's hard to follow off all these folks, and I'm sorry Amy has to go last because it's going to be even harder for her. But just to add a couple thoughts, and sorry I missed the earlier conversation, but the way I think about the Supreme Court decision is to say, you know, in general, the Supreme Court upheld almost the entire ACA. And I think that's really important to remember, including the new mandatory eligibility group, which is low-income people up to 133% of federal poverty. That is still a mandatory group now under Medicaid. Obviously, by saying that the Secretary of Health and Human Services didn't have the constitutional authority to penalize states by taking away their Medicaid funding if they don't expand, is why we are all saying it's in effect become optional. But that group is there, and that's been the first time in Medicaid's history that has been the case. And I think we have to remember that. As Jeff said, you know, we don't know what states are going to do. There's probably a subset that we can kind of be pretty sure about, but I think it's really going to depend. And there's many different things you can look at. You know, there's 25 states, plus Florida brought the initial suit the day the ACA was passed. 25 states joined it. 13 states wrote amicus briefs in support of the ACA. 2 are in both camps because their attorney generals and their governors disagreed. So, I mean, I think it just shows you that this is a very complex terrain, and with the match being essentially, you know, it won't cost states much to do this, and they're already paying for that care in different ways. So I think we really have to wait and see. But regardless, even if the ACA had been fully upheld, I believe that Ryan White would always be playing an important gap-filling role, not just for undocumented individuals, but for people who fall through the cracks in this country, which would happen. Now, with this new decision, I think it's going to be, you know, it's even clearer that Ryan White will continue to play a role be the safety net under the safety net, both for current, for states that maintain their current Medicaid eligibility rules, for states that maybe expand, for exchanges, for basically the healthcare system. It will play a different role, but it will still be pretty important.
Thank you. Amy, I'll turn to you, and then I'll also promise that I'm going to go the other way around the next time around. So.
I really appreciate that.
You're welcome.
Yeah, I don't have too much to add to what the other panelists have already said. I will say that I agree with Jen in terms of thinking about the decision. It was an incredibly narrow decision, and the Medicaid expansion was upheld. What was not upheld was the enforcement mechanism. So a state still has to actively not comply with a mandatory expansion. And I think that's important from a legal perspective and just sort of a messaging and framing perspective going forward. And that being said, you know, regardless of that sort of legal truth, I think we're still going to hear a lot from governors and from state health officials who are going to get out right away, right now, and say, no, we're not going to expand. And that's a fear. And I think, you know, the response in the states, and this is going to be a state battle, I think, you know, not just on the Medicaid expansion, but a lot of these implementation decisions, I think, are going to be kicked to the states. But I think, you know, some of the things that were raised are just going to be very important. This is a really good deal for states. This is 100% federal funding for 2014 through 2016, and then down to 90% following. That's huge, and that's an incredible amount of federal money to leave on the table. And while I think that's going to be difficult for governors to do, and then when you couple that with the fact that it was a very narrow decision, every other Medicaid reform stands, including the reduction of DSH payments. And that's you're going to have hospital associations and a whole lot of people who have a vested interest in making sure the Medicaid expansion goes forward and stays on your side. And the only other thing just to throw out there, so Arkansas, that's another state that, you know, not incredibly supportive of the ACA from the beginning. They have just done a report sort of trying to figure out what the Medicaid expansion would mean for them, and they've already found that it's going to save them $372 million from 2014 through 2022. So I think we're gonna look for more reports like that, and as states really do the math to push that math and to say this is a good deal for you. This makes sense from a public health perspective, but it makes sense from an individual health and from a cost perspective.
Do all of you understand the DSH issue, the hospital issue? I saw a couple of blank looks out there. If
you wouldn't mind just elaborating on it.
I will let my lawyers over there to remind them. But it comes up because, you know, the DSH payments are going to go away, the disproportionate share, so that the safety net hospitals who've gotten increased revenue because they take care of the uninsured, that part of the law is holding. So if you're in a state like mine in Kansas, the DSH goes away, but the Medicaid expansion doesn't, those hospitals are still going to be taking care of patients who don't have any mechanism of pay. And part of the reason they bought into the ACA is because of the Medicaid expansion issue. So as you kind of alluded to, the hospitals and the doctors have not always been aligned in what they wanted from the federal government, but I think in this particular arena, getting your local hospitals and hospital associations support to go to the legislature and the governor with you makes a lot of sense, because it's going to cost a lot of money if indeed they let the Medicaid money on the table and then they still have to take it in the teeth over the lack of disproportionate share.
Okay. So I'm going to shift slightly in terms of coverage options to the insurance exchanges. I'm sure we'll come back to Medicaid as well, but for folks that are over the Medicaid eligibility level, 133% all the way up to 400% eligible for tax credits that they can use to buy insurance in the exchanges. So, Amy, if you can talk from a state point of view, just what role AIDS advocates and their caregivers can play in the creation of these exchanges, but then a little bit maybe just about how the exchanges could play a role in people's ability to get HIV care from their providers of choice.
Sure. So, yeah, I mean, the exchanges are a huge piece of the Affordable Care Act. If you've got the public insurance expansion on the one hand with the Medicaid expansion, the private insurance expansion really comes through these state exchanges where people can get subsidies to purchase private insurance, and they're regulated exchanges. So I think, you know, that there are a couple of things to say. a lot of the details of what these exchanges are going to end up looking like have yet to be written. We're still seeing them. States have the option of running their own exchanges. I think about 15 or so have made the decision or passed legislation or executive orders to put in place a state-based exchange. And for states that do not want to operate their own exchange, the federal government is going to operate the exchange for the state, or some hybrid partnership model where the state will take on some functions. So that is all to say, I think that these exchanges are still being built, and we don't know exactly how they're going to work for anyone, never mind for people living with HIV. And that's a challenge, but I think it's an opportunity on the state side to really make sure that, just take out like the benefits package, number one, to make sure that the benefits that people are entitled to through the private insurance plans, through the exchanges, are able to meet the care and treatment needs of people living with HIV and other chronic conditions. We've gotten some federal guidance on the essential health benefits package. That's the 10 categories of mandated benefits that have to be included in every insurance plan sold through the exchange. But that guidance has indicated that there's going to be a whole lot of state flexibility. So I think from a sort of advocacy perspective, really trying to shape and influence that process. If your state has the choice, so every state has a choice between 10 plans to be its benchmark plan, and that's the standard for the scope of coverage that's going to be offered for people who get their insurance through the exchanges. So it has to include these 10 categories, but they're really broad categories. So I would say that one of the most important sort of advocacy points and implementation points is to make sure that those benefits packages are expansive enough to meet care and treatment needs. So just looking at prescription drugs coverage, I mean, that's huge. And the federal guidance thus far has not been so great in terms of making sure that every plan includes a robust prescription drug plan or coverage. So there are, I think, a lot of issues with the exchanges, and I think California is dealing with a lot of those. So I'll end it with the essential health benefits, because I think that's going to be huge. It's something that's moving. States have to pick their essential health benefits benchmark plan for private insurance sold through exchanges by September. It's a really big deal, and it's going to impact. We've got access to insurance on one hand, but we need to make sure that access to insurance means access to care, and the benefits really dictate what that means.
So rather than pointing at people, just if folks want to add to that, just jump to the microphone and pick up on those issues, or add other things that advocates should and their providers should be putting on the table.
Yes, so I'm living and breathing this right now, so I can't agree more. It's so critically important to have HIV care expertise at the table. And I think the message I wanted to bring here more than anything else is that nobody's going to invite us to that table. We have to insert ourselves in that process. And we've been fortunate in California that we've built up really good working relationships with other low-income healthcare providers and low-income health advocacy groups and other complex chronic conditions. So we just continue to try to bring HIV to that conversation, and we've found that that's been a really strong partnership for us, and it's critically important. But again, nobody will ask you to come to these meetings. You just have to show up, and you have to keep saying HIV, HIV, HIV. And hopefully somebody will hear you, and again, responding to regulations. And I know that for a lot of you, this might not be as relevant, but I think making sure that there's somebody that's looking at the regulations that are coming out, and making sure that things like Amy mentioned in terms of the formulary really addresses the needs of people with HIV, the provider networks, how we, one of the things we were surprised about with the Medicaid expansion, for example, was how we define network adequacy is very, very different. And so just having access to an ID doc, for example, doesn't necessarily mean you have network adequacy. So how are HIV providers identified in the networks, and how can we make sure that that really meets the needs of our population? So I think that's my main point to bring to this conversation.
Yeah, and what I'm hearing also is that obviously in states that have, let's say, recalcitrant governors and legislatures, it's vitally important to try to push and advocate. But even in states that traditionally have been very progressive and very forward-thinking, they have to make a lot of decisions in the next 18 months, or actually 12 months, because these exchanges have to be up and running by October of 2013. So don't assume that they're going to get this one right if there are issues that they need to address, whether it's adequacy or benefit package, to make sure that there's at least one or multiple voices that represent HIV providers, HIV patients in that discussion, because it's unfortunately fairly easy to make what seems like a small mistake or a small oversight in putting these things together that will affect how you operate, how your patients get care. So I think engaging in that conversation over the next year is really a significant role that you can play, as well as the advocates for patients nationally and state. Donna.
And I think turning your providers, I mean, the people here are obviously involved and interested, but you have a lot of providers, HIV providers, who are just in the trenches doing their work, and they're not really thinking about this. And they need to be brought to the table, and they have to be willing to participate in these networks and exchanges and plans. They have to fight for the ability to be in the plan, because if their patients are suddenly taken over or find a good exchange plan that they want to be in, but they're not in it, the continuity of care is gone, and those patients are going to have to come up with new doctors. So I think we have to have the provider network involved now, trying to say, yes, we want to be a part of this. How do you keep us to be a part of this? Don't exclude us.
Jeff?
I just want to add quickly, like, we also, this can seem overwhelming and there's all these technical details, but we're not starting from zero. You know, we dealt with these issues with the transition to managed care. I'm reminded in the late 90s, Sarah Rosenbaum of people at GW did all this work on contracting specifications. And when Jen Cates first went to the Kaiser Family Foundation, one of the first projects we worked on together was a consumer guide for a specific contract language about managed care contracting for people with HIV, dealing with network adequacy. So we have some of these tools that we need to dig out of our files to help us sort out some of this stuff.
Good point. Good point. Let me shift to, so implementation proceeds, the benefits start becoming available. A lot of people with HIV/AIDS, particularly who have relied on getting their care wherever they can, aren't going to be able to spend the time and energy to study up on all of this stuff. They'll need to learn about the new benefits and the new rights that they have. What role can their providers play in making sure that people who now have new benefits and rights, at least by statute, know about them and can exercise them? What are the sort of key worry points on those issues?
Well, for those of you who are providers out there, you know that you're the one that gets asked. Remember when Part D came out? How many of you spent a lot of worried time trying to figure out what to tell patients that wanted to know which Part D plan they should sign up for? I learned a lot more about it than I ever wanted to know. But I think we're going to be in the same position. We have to be able to know what's out there, whatever comes down the pike, and be that source of information. For those of us that have the luxury, at least right now, of case managers, a lot of that can be shifted to case managers. But there are people taking care of HIV that don't have a lot of case management. But I think the providers have to be the ones that figure out how to educate their patients or know where to send them, because we are the ones that are going to be asked.
Just to add, I actually think that providers need the education first. I mean, I think it's so complicated, and those of us who are focusing on it still are, you know, I have my resources that I go to daily to try to remind myself of all the nuances and intricacies of this. So educating providers, such as through this and through the Academy and through HIVMA and through AETCs and through, you know, other parts of HRSA, and not just HRSA. I mean, really finding the right ways to educate providers is critical. And I think, on the one hand, it seems like an overwhelming task. On the other, I think there's some targeting that can be done, because we're really talking about if we want to reach the maximum number of patients, there's probably a subset of places to start that education.
Jeff.
I just want to echo that. You know, some of this, you know, my former job, I remember a close friend and advocate coming in and talked to me, and they had this long list of all the things that people across the government, including CMS and HRSA, were supposed to do for them. And I think it's fair to say that CMS and HRSA should be doing things to help this transition. There's things that should be happening at the state level. But nobody should have a reasonable expectation that this is all going to be served up on a silver platter. And like Donna said, the questions come to you. So you also have to do your part, and you are the experts in your community. And you should look to federal resources to help you, but don't wait for them to do it. And part of me is shaped by this experience I've had of being on the inside, where I was not critical to the implementation of the ACA, but I was part of the team. Twice a week, I'd go to very high-level meetings and just saw how everybody, at not just Health and Human Services, but 3 departments, Department of Labor, Treasury, were working like 14 hours a day, every day, for years to do all this stuff. They are working so hard just to do the basics of implementing this law. And it's incumbent upon us to think about the other things and ask the questions, as Courtney said, what about HIV? What about HIV? So again, expect resources and support, but you all have a big part in making this work as well.
I just wanted to add, I think it's for those of us that have sort of Ryan White Part A planning councils, that putting that question to them is really important as well. And what we've been talking about in San Francisco is how are we allocating our resources now that we do have some of our primary care taken care of by these low-income health programs? Is there Ryan White money that we can reallocate to case management? And so far the answer has been no, but it's my hope that that will be an area that we can really invest in, and really making sure that we know, we define what that type of case management or benefits counseling is and what those people need to do, and what does the curriculum look like to get those people trained. And I don't think we need to reinvent the wheel there. I think that there are a lot of areas that we can look at, but these are conversations that we're really hoping that we'll have at a national level, but we're starting in San Francisco now. And then one other thing I wanted to mention is in California, we've also started, sort of by necessity, a stakeholder advisory group with our State Office of AIDS and our Department of Healthcare Services, mostly focused on how transition is happening on the ground now, because we are transitioning folks off of Ryan White. But as part of that process, hoping to look long-term toward 2014, because we're then, of course, going to have another transition, and what kind of communication networks can we set up now? How are we communicating with our HIV providers? Because we realized through this transition, we're not doing that very effectively now. And so that stakeholder group involves, again, government folks, but then also advocates, consumers of services, and providers. And we meet on the phone once a week right now to talk through these issues. So just wanted to mention that.
Okay.
Yeah.
Just real quickly, too, I mean, we have to think about the scope of what we're doing. We're talking about 500,000 Ryan White clients that are going to be largely transitioned. And we also need to think about triaging. I mean, I think we need to think about sort of 3 levels. A lot of people will get by with information or group education. Some people are going to need one-on-one assistance, and I think there'll be some complicated cases where people will need legal assistance. And I think in local levels, we need to think about how we're meeting the need. But there's no way we could give everybody a lawyer to get through this. And we really need to minimize the people that actually need one-on-one help, but some will need that. So.
I'm going to actually go off the schedule here a little bit and I'll open up for some questions now, and then I'll pick up with some other issues. So if folks can go to the microphone, gentleman in the front row was definitely the first, and then we'll take a few questions and then go back and forth between the 2 formats, if that's okay with folks. And again, if you can tell the audience who you are and where you're from, it helps everyone with that. Sir.
Good afternoon. I'm David Schmidt. For about 20-odd years, I practiced primary care HIV in Miami, just moved to Charlottesville, Virginia. One question that I have for the panel that doesn't have anything to do with Charlottesville, but in really an astonishing act of equivocal behavior, Congress has put forward this notion of across-the-board cuts. We're talking about expansion of social services, and I'm wondering whether anybody's really taking seriously the possibility that there will be across-the-board cuts in funding for healthcare, HIV in particular, but in general, and what the impact on the expansion this will have. And the second question I have has to do with something I noticed when I moved to Virginia. The majority of care for HIV in central Virginia is provided by infectious disease people, principally through UVA's ID clinic. I don't know what what ID providers are, what their feeling is and their support of Medicaid as a source of revenue. Certainly the university will accept Medicaid, but I don't know how many private infectious disease consultants will. And I'm wondering whether in that area there's going to be a further decline in primary care, comprehensive care for people with HIV because of what seems to me to be an inevitable shrinkage of infectious disease participation. And I just don't know to what extent the IDSA is involved in this conversation. I know I brought up three issues, the funding issue, the Medicaid and specialists, and the participation of our ID colleagues in this matter.
Okay. Who'd like to start us off? Jeff?
So I'll start with the first question. I mean, what you've raised really gets to sort of like what's a looming budget crisis at the end of the year and the potential for sequestration. And we could all, make ourselves sick worrying about what's going to happen. I don't think we really know. As it's structured, Medicaid cuts are sort of protected at the moment, but who knows how that'll play out. I think a lot of people hope that after the election we'll get some sanity. I think there's been a lot of consistent economic analysis that it really would be bad for the national economy if we implement these cuts. So I think we need to hope it doesn't happen and engage in the political process. The thing that's most worrisome to me is that the deal that they did strike that calls for cuts was pretty balanced between defense and non-defense. But if you read the news lately, you're only hearing a pushback on one side saying we can't make these defense cuts. So I think we need to start and make the case for why we also can't make these social service cuts and cuts in pretty much the rest of the budget. But I don't really know, like when people ask me these questions, I want to give specific advice on things we can do. I don't think we know enough now to really know how to respond to that. But you're right, it is worrisome that we're trying to take a big step forward with the ACA, and this could be really a step back.
I should know the answer. I'm going to come
yeah.
right back to you. I should know the answer to this question, but is Ryan White protected from the sequestration?
No, it's not.
So what size sequestration is
There was
set?
something in the paper this week that suggested about 12,000 ADAP clients could lose services. It's just one sense of the scale. I mean,
Yeah, I mean, the general percent cited as a 7 to 8% decrease over the current,
7 to 8%.
And it's imminent.
Further decrease of the current levels of funding for all programs generally. So that would, Ryan White included, CDC
AIDS
prevention included,
research, et cetera.
And the
global
issues-
AIDS included.
And the issues that Dr. Sweet brought up about the inability to recruit physicians to do this work is going to be further impacted by those cuts, which are imminent. This is a Damoclean sword that is there now.
Oh,
Courtney.
Yeah, just wanted to add that, not to be too doom and gloom, but we're also seeing this. I mean, we're operating in a budget deficit environment in the state too, and so we're trying to do all these sort of innovative and creative things with no money, and in the face of other cuts to our social services from the state perspective as well. So I definitely hear what you're saying, and it's a struggle on a daily basis. But I think it is something that we responded to really strongly last year as an advocacy community around seemingly very similar situation last year, and it seems like we need to step it up again this year. But it's always a challenge, as you mentioned, to really figure out when and where to engage and how to really be effective in our advocacy.
And to answer your ID questions, HIBMA's here, IDSA is back here, and they've been very involved, as has the Academy. But one of the things that I have been involved with and through Health HIV is trying to get more primary care people who are very good providers involved in HIV care. It is not what it was in the mid-90s. We all know that. There's still a need for ID specialty at some points, and for ID people who want to do this and sign up for Medicaid, that's fine, but I think there might be a dearth of those. So trying to get where the new money is going, which is the FQHCs, the CHCs, and try to get some of those very good clinicians more involved, and truly, they're supposed to be based on a medical home model. That's the way the FQHCs are supposed to work. If they're a medical home, they should be a medical home for all of their covered lives, and they shouldn't be able to exclude HIV care just sort of automatically. So we're putting together kind of a workforce plan and trying to do some mentoring so that for some of the FQHCs that are interested or have an interested provider, we can give them the expertise, help them develop the information and other things, and be mentors so that they have somebody to call on. All of you know, I think, that the hardest thing about being a sole HIV provider in an area is being the sole HIV provider and not having somebody to bounce things off of. So if you can give people some support, then very good people might learn some improved skills, and we might mitigate some of this workforce issue. But I think that your Virginia model is true in many places, and I don't think a lot of outpatient ID people are going to want to continue Medicaid rates for a great deal of their care. So I could be wrong, but I do think that it's important that we continue to try and educate people that are in the healthcare homes where these patients are supposed to be going, if we can get a few more of them to take care of them with our help, then we will continue some of the very good care we've been able to give people with HIV.
Can I just add one quick thing? The Medicaid, there's the increased primary care rate in Medicaid under the law as well, which is 2 years, but clearly sort of the push, at least in California, and I think this is a nationwide trend, is for people with HIV to move into more primary care settings for their majority of their care. And so it's also critical that as we talk about what that looks like, that we have HIV care expertise in those dialogues as well, because that's going to be that's clearly where we're moving, and we just want to make sure that's done well and with providers that have some HIV experience leading the way.
I mean, related to that is the issue of having an HIV specialist count as a primary care doctor to be able to access those enhanced rates, since in many cases the HIV specialist is serving in that function too. So.
Right. Can I just add one thing to that point?
Yeah, but just for those who don't know what the primary care increase, can somebody just quickly describe what the 2-year provision does?
Well, you get Medicaid rates become Medicare rates, and many people don't like Medicare rates. So it's, I mean, it's a bonus, but it's better than just Medicaid, but it's still just Medicare rates. And then there's the 10% primary care on top of that. If you are a primary care specialist who's, 60%, 70% of your billing has to be the appropriate 60%. 60% of your billing has to be the appropriate E&M code. So if you're much of a procedurist, you get knocked out of the primary care 10% pretty quickly.
So, and just to clarify on that point, so it's limited, right? And I think everybody would agree that it's not the best. But Medicaid reimbursement rates certainly a barrier to getting providers who are qualified and who are willing to see Medicaid patients. But I will say one sort of good thing about the regulation, it went a little bit further than I think people expected it to do in sort of expanding the world of who's going to be eligible for that enhanced rate. And again, the Medicare rates are still not great, but they're better than Medicaid. So what the regulation says is that if you're a primary care provider with a specialty designation of family medicine, general internal medicine, or pediatric medicine, or subspecialty, you're eligible. And then if you're not board certified, there's another way to figure out if 60% of the codes in the past year that you've billed for are for primary care evaluation and management codes, then you're eligible. So I think it was better than people expected it to be, and I think it's still going to be work to make sure it's implemented in ways that incorporate the expertise of HIV providers.
And which 2 years are they?
It's 2013 and 2014.
Okay, thank you. Gentlemen? No, thank you.
Since transitioning from public to private care, I have been made acutely aware that there are several layers of Medicaid. One is traditional Medicaid, the other is managed Medicaid. Managed Medicaid does not pay their bills. In fact, we've had to drop to levels of managed care programs because just in traditional family practice, they weren't paying their bills on time and have refused to pay. And then we've lost several $1,000s on procedural payments. And in the last 2 years since I have transitioned into private care, a lot of the local Ryan White personages are being transitioned into Medicaid services, and I am getting those people. But they're having a hard time with the formularies and the types of programs that they're being either forced into or told that they have to go into or choose from. So as providers, we need to be aware of those programs that are offered in each state. We have ICHEA, which is an Indiana high-risk insurance pool managed by Anthem that was traditionally covering what wasn't covered by traditional insurance for the high-risk populations like HIV-positive people. Then there's traditional, which paid, you could get on it. It took you a long time to get on it, and once you got on it, they took care of everything. And now there's managed care Medicaid, which they don't pay, period. And the formularies suck. And the reimbursement is even worse than traditional Medicare and Medicaid. So as providers, my point here is you need to be aware of the programs your clients are being transitioned into.
And I just want to thank you for that point, and that is what we're experiencing in California is all of our seniors and persons with disabilities, which includes all of our people with HIV that are in fee-for-service Medicaid, just transitioned into Medi-Cal managed care. And so as we look towards 2014, that expansion population, at least in California and I think most other states, it's going to be a managed care plan. And so that's why I was trying to make the point earlier about what that plan looks like is so critically important, and what the formulary looks like and what the network looks like. That's all what's being decided now, and that's really where we need HIV providers to be informing that process.
And again, we're back in the same old position. What happens when a lot of providers refuse to even take Medicaid? You're back needing a program similar to Ryan White. So it's a big Gordian knot type situation. You're darned if you do and you're darned if you don't. And it all stems on whether the providers will take Medicaid coverage and what they provide.
And I would just add that yes, I agree, but I don't think it's all as doom and gloom as that, and maybe this is, again, just my California perspective, so please take this with a grain of salt. But I think that we have a real opportunity here, so I do think this is a challenge, but it's a real opportunity to design the system that we want, right? We're not asking about a technical problem. This isn't something that we can fix. This is really new thinking, and how can we make sure that the system we create takes care of people in the way that we need it to take care of people, and then working with people like Jeff about what does Ryan White look like in this new environment, and how can Ryan White fill in the gaps, and how can we really create a system that supports people to stay in care that we know they need. And so there are, California's we've had a lot of challenges, but I think that there are a lot of things that we've done right. I think Los Angeles County, for example, and how they've set up their low-income health program is a model that we might want to look at in terms of how they define things like case management and mental health care and substance abuse care. And some of that we want in the network, right? But as HIV providers, some of that we don't want in the network, because that means we can continue to use Ryan White to cover those services. So how can we be creative here? And given that this is where we're moving, how can we make the best of this opportunity is how we're trying to approach it in California, kind of just because we have to, because that's where the train's moving. But I do think we can't understate the benefit to clients when they successfully transition into these new coverage. We have seen, even in San Francisco, where we had pretty good access to care already, clients are seeing great improvements in their access to care and what services they can access. So I don't, I know that it's scary times, but I don't want to sort of forget about that part of it either.
Okay. Our next question.
Great. My name's Tyler Termier, and I suppose I'm here wearing 3 hats today. One as the executive director of the Ohio AIDS Coalition, another as the chair of the Board of Trustees for the National Association of People with AIDS, but most importantly as a 29-year-old black gay man who is living with HIV over the last 9 years of my life. And I don't know that I'm going to ask a specific question, but more so highlight a couple of things that I've heard today that I think are not necessarily going to be earth-shattering to anyone in this room, because we all are following the issues, but are some of the real issues that that myself, as someone living with HIV, as well as the clients that I'm working with in a state like Ohio, who is also wavering on whether or not they should expand to Medicaid, faces. I think, Jennifer, you made an amazing point by saying first we need to educate the providers. I run an organization that is solely charged with educating both providers and clients in both leadership and education opportunities every day around the year. But our providers are lost, and they have, I think it's taken so long for so many of us who are following these issues to feel even remotely comfortable to talk about them in a setting like this, but try and get a group of providers who already have too many patients on their docket, or case managers who are going to be expected to explain these things to clients who already are seeing 100+ clients on a regular basis in a room, to talk to them about the nuances of what these programs are going to mean and what the road ahead looks like. So I guess I challenge us all to think about beyond just saying we need to figure out how we translate to the local level, but really engage in a national conversation about what it really is going to mean to make that happen. And I think the National HIV/AIDS Strategy is a great example in that it's a wonderful document, and great things are happening in many places. But then take a place like Ohio, for example. The National HIV/AIDS Strategy is that good old strategic plan that's sitting on a shelf, compiling dust, because providers and community-based organizations have no idea what it means for them at the state level necessarily. And I think there's a lot of people who have responsibility in order to make those things come to fruition. I'd also say that I think we're having a really great conversation today about what this road looks like as we travel towards 2014, and that we have a lot of challenges, but it's also a really amazing opportunity for us to design what the systems are going to look like. But beyond just figuring out how we're going to get providers at that table, I think it's crucially important that we figure out how we are going to have the meaningful involvement of people living with HIV at the table and in these discussions. I think, for a long time we have struggled with trying to figure out how we just get the greater involvement of people with AIDS and just get someone that can sit at the table, that can fulfill requirements within our community planning structures or within our national conversations. But what does it really mean to have meaningful conversation of those people who are living and breathing this disease every day and are going to be impacted so greatly by this? And beyond that, how do we translate it to all of this to the local level, not just so that providers can understand it, but so that those providers can best educate the clients that are going to be impacted. And I think one of the greatest challenges that I have, I just spent the last year and a half working on the national level, and now I'm back at the state, and I've seen I've lived both worlds, so I know the challenges, and I'm trying to help a state that is greatly in need of the major reforms of the Affordable Care Act. But the people in my state have no idea how to navigate this system. And I have people from my state health department calling me, asking me questions about the Affordable Care Act and what it will mean. And when I challenge them back about having someone working on it at the state level, they go, "Oh yeah, we don't have anyone working on that at a meaningful level at this point. We don't really know how to navigate this system." So I think that the conversations are happening, but there's still so much we need to do to empower our state health departments and our community-based organizations to involve people with HIV in the process, but also for our national organizations to be providing the resources that are going to be condensed enough, which is, I realize, a challenge, but condensed enough and useful enough that a provider will have the time to read it and then educate the clients that are going to need this information the most. Thank you.
Thank you. Reactions or comments?
I have
Courtney?
I have a lot of comments, but I definitely feel your pain, and I am in a similar situation, I think, in our state. Is obviously more further down this road, but we get questions from our state all the time. There's a website called HIVhealthreform.org, and we do webinars once a month right now on sort of the nuts and bolts of healthcare reform implementation at the grassroots level, what it means. As much as anybody wants to participate in those are open and available, and all of the webinars, I believe, now are on HIVhealthreform.org. You can listen to them from, I think we started in January. So that's about 6 months now worth of webinars that we've done. There's fact sheets and information on there that we're generating and presentations that you can use if you want to give presentations about what health care reform means and just need a presentation to use. Please, they're there, they're available. And then also, I think as much as you can, if it's possible, again, I mentioned this task force that we've just started getting together on a weekly basis right now because it's so pressing, but even on a monthly basis, just talking through some of these issues. There is nobody that knows these answers, and that's what I found out. It was really sad to find that out, but it's an opportunity for us to really figure out what this is going to look like and what this means, and obviously cannot be done without including providers and people living with HIV in a very meaningful way. And so that's what we're trying to do, and it's a challenge, but we're doing it every week. And then also at the local level, having a similar task force that meets monthly, just talking through some of the nuts and bolts, because it really will be implemented at the state and local level, in terms of where clients interact with the services. So that's really a big area of focus.
I just want to take this time to plug what she's talking about. There's a FAPP, and if you're not involved and you want to be more involved and hear what's going on, get on some of the calls. It's the Federal AIDS Policy Partners, FAP. But there's two work groups that I listen to every time they meet, and that is the Healthcare Access Working Group and the Ryan White Reauthorization Working Group. And there's over 100 organizations, and it's all of these very bright people that kind of follow all of this. So it's a way of getting on and trying to listen to what's going on every month and sometimes every couple of weeks. So if you're not involved in that and want to be, you really should kind of contact somebody, but it's well worth your time if you're really going to try and understand it locally.
Our next question.
I'm Keith Barton, and I'm from Oakland, California. I worked in the AIDS clinic in the county jail in Alameda County, right across the bay from Courtney. And my impression is that a high percentage of the people with HIV in corrections, jails, and prisons, by and large do not take medication when they are out of custody. A relatively low proportion of them take medication. And even though I made extra efforts to refer them to the Ryan White clinics in Oakland, my sense is that relatively few of them went. I just want to bring this to your attention that there is a large proportion of people with HIV who do not even take advantage of the Ryan White facilities that are available. And obviously, this contributes to the transmission of HIV. I believe the figures are about 20% of people with HIV pass through corrections at some point in the course of a year. And the incidence of HIV in corrections is about 2 or 3 times what it is in the general population. So it's a significant population for people to be aware of. I'm currently doing policy work in New Jersey, and I'll say that the AIDS Coalition of South Jersey actively goes into jails to meet with people and get a face-to-face interaction with them. And I think that's a viable strategy for trying to bridge this gap. Another thing in terms of bridging and coalition is that I suspect a large reason that people don't take HIV medications is that that even though they could access them through Ryan White, they are dealing with addiction problems, and that that is another category of services that we need to be actively involved in bridging and making available to people with HIV.
I just want to respond quickly. I think you point out a real weak spot and something we need to address, but I think the federal agencies are aware of it. I think HRSA is doing some work in this area. SAMHSA and the Bureau of Prisons, the Department of Justice are all doing some work specific with people with HIV. So,
all right. I want to make sure we get to all the questions, so I'm going to ask for short questions and short answers to make sure that everybody gets at least a chance to ask their question that has one. Sir?
So my name is Keith Rawlings. Spent the last 20 years in practicing medicine in Texas. And one of the questions that I have is that the variant in Medicaid program coverage is all across the board. And while expansion in California, while wonderful, will get you to one level, expansion in Texas, Louisiana, Mississippi will get you to something very different. In those situations where you particularly have those states that have low Medicaid either reimbursement or Medicaid coverage, because in Texas, for example, three drug coverage for a Medicaid patient, independent of what you have, is very different than unlimited coverage, say, in Massachusetts. How will the Affordable Care Act address that kind of disparity that already exists within the context of the Medicaid systems, even if you expand it? And are we not just simply saying for those who are HIV positive that you need to move to California if you live in certain states? The other question is, and this I think is really just specifically aimed at you, Jennifer, can anyone tell us a volume of individuals that we're anticipating in the HIV world that would be moving from Ryan White into the Medicaid structure, to get some idea on a national level what this actually might entail? Or, I mean, we talk about it from the local level, but what kind of volume are we actually talking about?
Okay, thanks. Jen, you want to start us off?
Sure. Just on that second question, and on the, well, actually on the first question, might not answer it completely, but I think one of the downsides of the way that the Supreme Court ruling happened is that before, with the ability to enforce the new category, there would have been a floor across the country of 133% FPL. And while that floor, and that in many places would raise the bar, in other places they're already above that. So, but I think that has presented it will still could get better in a lot of places, but there'll be a variance, and that's a real challenge. On the second, I will say that we at Kaiser are doing those estimates now. It's a lot harder to do after the ruling because we could say, we're looking at, well, if all states were to do this, this is what it might look like. So there's not going to be any magic here, and it's not as easy as just saying everybody on Ryan White or everybody in this place. And one of the challenges that we're running up against, and this is not a surprise to anyone here, is there's no single data set that really provides an easy answer to this question. And so we're looking at different data sets. I know that HRSA is looking at this question, and ASPE is looking. I mean, a lot of organizations are looking at it. It's not a simple one to answer, but it's an important one to answer.
Yeah, and
Amy.
just to add a note to that, to the first part of the question, I think the advocacy community writ large was really hoping for more of a federal floor across the country so that you wouldn't have such variation in the benefits that people are able to access, whether you live in Texas, California, Massachusetts. And that unfortunately didn't happen. And I think what we're seeing a lot more of is that there's just way more flexibility on the part of the states to implement the Affordable Care Act. And so just looking at the benefits provisions and just looking at the benefits provisions for Medicaid, so we've got some standards, the essential health benefits, those 10 categories, same 10 categories that are required for the private insurance plans and exchanges are going to be required for all the newly eligible beneficiaries in Medicaid. So that's huge, but what does that mean and how does that get implemented? And what I think we're going to see, states are going to have a lot of flexibility to pick the plan for their newly eligible beneficiaries, and I think that there's going to be sort of a knee-jerk reaction in some states to have that plan be less comprehensive than we need it. And then we've got a state advocacy issue. And just to bring out Texas, for instance, certainly that's a state where I think the advocacy is more challenging than in other states. And just, 3-4 months ago, there was a major decision about whether to move or to have the 3 prescription drug limit that's currently for fee-for-service, whether all the managed care organizations were going to have that 3 drug limit in prescription drugs. And, that was an opportunity for HIV advocates who are in the room to get together with all of the other advocates and people who are going to be directly impacted by that and say, this is crazy. And it doesn't make sense from a public health or individual health perspective, but it doesn't make sense from a cost perspective, because what are you going to do with all those people who need far more than 3 prescription drugs per month? So I think that's just sort of an example of where these advocacy fights are going, and that's going to happen in Texas, and that's going to happen in a lot of these states, because at the end of the day, those benefits decisions, a lot of times, they're going to be taking place in state Medicaid offices and state legislatures.
Jeff.
I just want to add quickly on that. Those are the kinds of battles that do need to happen at the state level, but we can win. There's been a really worrisome trend, specifically on drugs, a number of states imposing limits on drugs dispensed. A number of states, though, have exceptions for ARVs, for example, or they have other exceptions for mental health drugs. I think most legislators, they don't say, we need to do this because we want to keep these people with HIV from getting their meds, because they generally see them as being cost effective. But it often does take education, you know, so I just think we can win some of these fights if we engage.
I just wanted to add quickly that Texas, I think, has some really fierce state health advocates, and I believe they now refer to themselves as the honey badgers. So I wouldn't count Texas out yet, and they are working really hard on the ground to make sure that that program is as good as it can be. But I also think that your question raises the point that Ryan White is not, the need for Ryan White will remain even after healthcare reform is implemented because of the variation in programs from state to state.
Next question.
Well, I just wanted to share my experience to follow up sort of on what Jeff said in some of this conversation. You know, and I'm from Arizona. I'm Kevin Carmichael from Tucson, Arizona. Arizona was the last state to get Medicaid, and it's always been a managed care plan. And so I think what we need to recall is that we have a lot of power. We as the providers and we as HIV advocates, when we get into a managed care environment, those managed care plans are responsible for our patients. And we can spend a very large amount of money if we let people get sick. That money is going to have to be spent. We can make the case, there's lots of data to support that taking good care of people with HIV saves money to the plans. And that may not resonate too well with a legislator, but when you're talking to a medical director, it really resonates with them. And so I think we have to have our advocacy at multiple levels, but in some ways, a managed care environment is actually a very good one for us if we do our homework and really go to the medical directors. And I've been generally successful when I go to a medical director who initially they deny me a drug or deny me a test or whatever, and I go back and I tell them why I want it, and I try to be, I'm actually fairly reasonable usually, and generally you can get what you want if you can prove and if you work and let them know you're trying to do the best for your patient and you're trying to save them money as well. So we do have a lot of leverage here. I mean, it's a gloom, you know, we hear a lot of uncertainty and people are frightened, but we do remember we do have a lot of leverage, so I want to maybe interject a ray of hope there, and managed care may not be a bad thing for us. It may actually be really good for us.
Okay.
Thank you.
Thank you. Yes.
Hi, I'm Ann Bagchi, and I'm like the other person. I'm kind of here wearing several hats, one of which is that I'm a senior health researcher at Mathematica Policy Research, and we're doing some research kind of on this topic. I don't think I can say too much about that, but one thing I did want to follow up with what Courtney was saying, and to, in a way, I guess, kind of convince people in the room that it really is an issue. But this whole thing of being at the table and not being invited to the table, I'm actually hearing states actually kind of saying almost as if it's a good thing that they're not bringing people to the table. It's like we don't discriminate. They think of HIV as the same as any other chronic condition, so we're not designing things with HIV in mind because we want it to be the same for everybody, so we're not discriminating. And so that's, and I just wonder kind of too, as a question, how do you address that kind of way of thinking?
Well, I think that if you tell them what happened in California when they forgot to bring or wouldn't bring people with HIV to the table, that hopefully that'll start the conversation. What happened in California was that because people with HIV were such a small proportion relative to the overall population that was being considered, we didn't rise to the level of needing to be at the table from their perspective. But what they weren't understanding is that we bring with us this Ryan White money, this $2.4 billion federal appropriation, and they really didn't understand how that program worked at all, and to a large extent still don't or have a lot of questions about how that program works. So in the end, that ended up being a lot of our power, is that we were really going to be impacting their systems of care because of the money we bring with us. So I don't think that that's the ideal way to get in the room. And I should just add, I mean, this is in California where we have very good relationships with our Department of Healthcare Services generally, or we did, and I hope we still do. And even then, they didn't really think of us. So I can't overstate enough how much you just have to insert yourself and just keep coming back. And even if you're a pest, it doesn't really matter because I'm one too, so you're at least in company. But yeah, you just have to keep inserting HIV.
Yeah. Two other thoughts on that, and one is one we've been saying for a long time for those of us who work in HIV. If you can't do it right for people with HIV, you're probably not doing it right for a lot of people. So it provides a way to say, this isn't a self-serving thing. This is really about a population that we've learned a lot about treating and access and many issues, so it would be in their interest. But secondly, I think another newer way to approach it is with new research showing the incredible power of treatment as prevention. It really shows the public health implications of getting people with HIV on and treatment and access as much as possible in addition to the clinical one, and it provides a new argument, I think, for why a state should be interested in thinking more seriously about this.
Thank you. Yes, sir.
Hi, I'm Andy Cates, and I am from California, and I'm an advocate. And just, you know, it seems like California is being painted as somewhat of a Garden of Eden in a sense, and it is a little bit bumpier than that. There's people that I know that I advocate for that in the Medi-Medi shuffle have been shoved into care situations with physicians that have no experience with HIV. They've got very complicated scenarios with complicated medications, opportunistic infections, and they've been sent places that are dozens of miles away from where they actually live, and they don't even use transportation, or they don't even have transportation to get there. So, I mean, a personal story is I got shuffled. I'm a guy. I mean, I don't think I look too female, and I got shuffled to a gynecologist. So that's how ridiculous it can get, and that's troubling to me. And if California is as forward-thinking as we all think it is, and we're leading the way to, you know, follow us, we're doing it great, that's a problem. And in respects to what Donna was saying, I think when you talk about shifting care of HIV-infected individuals, you know, spreading the wealth or whatever you want to refer to it as, to general care practitioners that maybe don't have the experience, I think there's a step that is skipped as far as bringing them to the table. They won't even ask, independent of guidelines, for an HIV test right now. They're scared, it's icky, they don't want to talk about it, and it's definitely not table talk. So I think, unfortunately, the challenge is just to get them to open the door.
And I certainly didn't mean to paint California as a Garden of Eden. I mean, we've been struggling.
She hasn't been doing that outside of this meeting.
That was not my intention. We've been struggling with the transition to managed care, and it's been extremely frustrating. You know, clients getting shifted into pediatric clinics, and it's not just us. I mean, it's not just people with HIV. It's, you know, cardiac patients. It was very much an example of how not to do a transition of a vulnerable population. So that's what I'm trying to help people prevent. But I think it raises a very good point around what are patient protections in the process. And it's something we haven't really talked about that much here, but it's critically important. The patient protections that were in that transition that did exist completely broke down. So it's something that from an advocacy perspective and from a provider perspective, we need to pay a lot of attention to. And then I had, and it's the network adequacy thing again, and how do you define, you know, when we were talking to Department of Healthcare Services about that, they didn't understand that someone with HIV needs to see not necessarily an HIV specialist, but somebody with HIV care expertise of, you know, some definition, and that they didn't even know that. So again, that's in California, and I think it just points out that we do have a lot of work to do, but I don't want to make it so doom and gloom that it's unattainable. I mean, I think it is something that we can strive to achieve. It's just something that we all need to learn from and figure out how to move forward. But your point is very well taken, and it has been a really rough couple of years for us in particular.
Okay. Our last question. That's you.
I have a comment which actually comes on the tail of that comment pretty nicely. My name is Christian Ramers. I'm at the University of Washington in Seattle, the other Washington, and I work at the Northwest AETC also, and I'm very interested in this issue of who is going to be the one that assumes the role of caring for HIV. And so I'm the medical director of a telehealth program, which is sort of a new model, and it speaks to what Dr. Cha said about this being an opportunity for innovation. We got a HRSA grant to start providing telehealth support to FQHCs that were willing to take on some HIV. And the model is that I'm an infectious disease specialist who is very interested in HIV, and we basically are sort of mentoring, just like Dr. Sweet had said, by distance, primary care doctors and FQHCs that are willing to step forward and take on HIV care. And it's been going really well. It's a grant-supported mechanism, so sustainability is a very big concern of ours, whether this is going to go, but it's called Project ECHO. And it works to support people that are willing to be primary care docs that take that step forward and say, I will care for HIV people. It's rewarding for me as an HIV specialist to feel like my reach, and all of you that are HIV clinicians, that your reach can go beyond your own clinic. And I just think it's a nice opportunity to address some of these really big challenges that we have ahead of us. So, thanks.
Thank you. Well, I appreciate the last comment in particular. I mean, all points of view obviously are extremely valuable. I do think we have to come back to the optimistic level of this, that this is, with all of its ups, downs, and very difficult issues that we're going to have to work through, a major advance for not just people with HIV/AIDS, but all people who live with imperfect health or might in the future, which is all of us. I wanted to see if any of our panelists had any closing or any other point they want to make before we conclude the panel. So, anybody? Well, great. Well, please join me in thanking these terrific panelists. And I know we want to thank the people who have gotten up to ask questions and make points. It's really enriched our conversation. So thank you.